I'd like to introduce Julie Iddon. She's a consultant breast surgeon at East Lancashire Hospital Trust. Please could you explain the epidemiology of breast cancer, including the genetic basis?
Well, the epidemiology of breast cancer is that it's a very common disease. It affects at least 1 in 9 women in their lifetime. And over the last 30 years, the incidence, so the number of cases of breast cancer diagnosed every year, has doubled. At the same time, survival rates have improved. Deaths from breast cancer have decreased by about 10% annually. The thing about breast cancer is it's mainly a disease of increasing age. So of the 50,000 cancers that are diagnosed annually in Britain, 80% of those will be in women over the age of 50 years. Breast cancers in younger women account for a much smaller proportion. So for instance, a woman below the age of 30, women below the age of 30 only account for about 1%, less than 1% of the total number of cancers, and women below the age of 40 only for 2% of the total numbers. Age is the biggest risk factor, and then genetics is actually the second biggest risk factor. So women who are known to carry one of the genes known to be associated with breast cancer, such as BRCA1 or BRCA2, the individual who carries the gene has a personal risk factor of about 80% of developing breast cancer. This is because the gene is an autosomal dominant, so it's passed on from parent to child, and each child has a 50% chance of inheriting the gene. But although you have the gene, you may not necessarily develop breast cancer. That happens in 20% of women. However, you can still pass the gene on to your children. Having said that, the other side of the coin is, although women with the gene are highly likely to develop breast cancer, in women who develop breast cancer, less than 5% will have one of these genes. There are a number of risk factors that are known to be associated with an increased likelihood of developing breast cancer, some of which you can intervene and reduce your risk, some of which you can't. So obviously, increasing age, we can't stop getting older. However, we do offer breast screening in the UK to women between the ages of 47 and 73. This has the opportunity of picking up cancers at an earlier stage and improving survival and treatment. If we go on to look at other risk factors, which are outlined on the slide, as well as age and genetics, a past history of benign breast disease is a risk factor for an increased likelihood of developing cancer. The highest risk comes from having an atypical proliferative disorder. So this is things like atypical hyperplasia or LCIS, lobular carcinoma in situ. This gives a relative risk about 4 times the normal population. Other benign diseases, such as simple fibroadenomas and microcysts, do not increase the risk of breast cancer. But there's a small risk in the region of about a relative risk of 1.3 with highly proliferative fibroadenomas or palpably large cysts. The next risk factor would be exposure to radiation, particularly in the years of breast development between the ages of 10 and 25. So in this country, that relates to things like radiotherapy for Hodgkin's disease. Those women should be invited to their own screening programme because of this risk. Other risk factors include family history where there isn't a known gene. So sometimes in some families, known genes like BRCA1 or BRCA2 aren't detected, but there does appear to be a heritability of breast cancer in that a large number of relatives in the family will have developed breast cancer. So again, if you have a first-degree relative, that is a mother or a sister, who's developed breast cancer below the age of 40, or a relative over 40 who's had maybe 2 breast cancers or a breast and an ovarian cancer, in these situations you may still have a high risk of breast cancer. People with family histories like this, a young first-degree relative more than one first-degree relative or 3 or more second-degree relatives are eligible to be assessed by the family history clinic. Other risk factors are things more related to lifestyle. So these are things like your exposure to hormones throughout your life. In particular, it seems to be cyclical hormones and the use, so that's things like the number of menstrual cycles in your lifetime, or the use of estrogen and progesterone-based HRT can increase your risk of breast cancer. So this is related to things like we know epidemiologically early menarche, late menopause, not having any children, or having your first child over the age of 30 or 35. All of these can slightly increase your risk of breast cancer. In terms of exogenous hormone use, hormone replacement therapy does increase the risk of breast cancer whilst you're taking it. And likewise, there's a very small risk with the oral contraceptive pill. But again, this declines some years after stopping taking it. Finally, I think the lowest known risk factors are more to do with lifestyle factors such as obesity and alcohol. Women who gain weight between the ages of 20 and 40 have been shown to have an increased likelihood of developing breast cancer, and people who become obese postmenopausally. Some studies have suggested that for every kilogram in weight that you gain, you increase your personal risk of developing breast cancer by 1%. Conversely, some studies have shown that if you exercise regularly, you can actually reduce your risk of breast cancer. So women do have the opportunity to reduce their personal risk by regular exercise and maintaining a healthy body weight. Alcohol, again, it's been shown that if you drink more than 10 grams of alcohol on a daily basis, again, you have a slightly increased risk, a relative risk of about 1.3 of developing breast cancer.
How should a GP examine the female breast?
I think the first thing is that it's important that you ask the patient to get undressed so that you can perform a thorough inspection. So ideally the patient should be undressed from above the waist. Breast examination has 2 parts, inspection and palpation. I would recommend that first you examine the patient sitting up. Inspections are a very valuable part of clinical examination because you're looking for asymmetries and sometimes you're looking for very subtle signs. So whilst you've got the patient sitting up, you're also going to ask them to move their arms. So you're going to ask them to move their arms above their head, I can demonstrate, and onto their hips and press in. And this will sometimes make any skin dimpling or asymmetry evident. If a woman has larger pendulous breasts, while she's sitting up, you can take her hands and ask her to lean forwards because, again, sometimes as the breasts move away from the chest, you can see lesions or skin dimpling. Whilst the patient's sitting up, I would go on to examine the lymph node fields. So the lymph node fields we examine when considering potentially a breast problem are the supraclavicular fossa and the axilla. I like to do this sitting up because I think when you examine the axilla, gravity helps to bring all the tissue down onto your fingertips, so you're more likely to be able to feel an abnormal node if it's there. Then I would ask the patient to lie down. Normally you want them to be reclined comfortably at about 45 degrees or less. And if you ask them to put their hands behind the head, this stretches the breast out flatter across the chest wall. When it comes to palpation, I don't think there's any right way or wrong way to do this, although people have described different systems. I think that the important things is that you've examined the whole of the surface of the breast. You can either do this in concentric circles or concentrate on it as a quadrant by quadrant exercise. If you use the flat of your hand, if you use the flat of your fingers, this is the best way to generally examine the breast, and you may use your fingertips if you're drawn to an area that feels different. But try to avoid using your fingertips to examine the whole breast, because you will find that often the whole breast feels lumpy, and you'll find you think hundreds of lumps. The other thing that's really useful to do is to assess symmetry, and I often do this by palpating both breasts symmetrically at the same time, because sometimes you can feel things that you can't necessarily see. You can feel subtle differences. The other important thing is also to ask the patient to show you where the lump is that they have felt, because I think it's very important that you know what it is that they felt and make sure that you can feel it too, or if you find something different, then you can point it out to them.
Who should we refer to breast clinic?
For referral to breast clinic, anybody who has a new discrete lump. So if you feel something in the breast that's quite obviously a lump and separate from the tissue, they should be referred up to be seen and assessed. The other large group is people with asymmetrical nodularity. Certainly if a woman is postmenopausal, she should be referred up to clinic immediately. In younger premenopausal women under the age of 35, this could simply be hormonal changes, so I would suggest bringing them back after the next period to re-examine them, and then if it's still asymmetrical and nodular at that point, they could be referred to clinic. Other symptoms that require referral would be nipple discharge. So if this discharge is spontaneous, blood-stained, or single duct on examination, they should have that checked out. And changes such as eczema on the nipple, again, a trial of treatment can be tried with a mild hydrocortisone cream, but I think anybody who's got central eczema on the promontory of the nipple, they need to go straight to clinic. Other things, the more subtle things, so if there are changes such as skin dimpling or asymmetry, often they can be a subtle clue that there's something underlying in the breast. So again, I would refer those people up to clinic. The final group is women with breast pain. This can be difficult sometimes because most of these women won't have any underlying breast pathology. But certainly if I would hope that people with obviously cyclical hormonal changes, so premenopausal women with bilateral breast pain, I would hope could be managed mainly in GP practice. But an older postmenopausal woman with unilateral pain, again, I would probably want to see her in the clinic.
What are the relative merits of surgery and chemotherapy?
Well, surgery has been the traditional first-line approach to breast cancer. And as the years have gone on, I think it's become evident that the role of surgery is really for local control. We know that more aggressive surgery, as was practiced in the 1950s, for instance with the Holstead mastectomy, which removed breast and skin and muscle, although it was very, very good at reducing the rates of local recurrence, didn't improve survival in women with breast cancer. Unfortunately, despite this radical surgery, women still went on to get distal metastasis and die from the breast cancer. So surgery is good for local control, but if you want to improve survival, then it needs to be an adjuvant treatment that treats the whole body systemically. We do have some ways of predicting which cancers are more likely to have shed cells that are going to be able to survive in distal organs. And we use these criteria such as tumour grade or the absence of estrogen receptors, the presence of Herceptin receptors, to determine who should have chemotherapy as adjuvant treatment. But the idea is that chemotherapy circulates in the body and damages any cancer cells that may be lying dormant in the bone marrow or the liver. although you've asked me about chemotherapy, you've got to remember that there are other systemic therapies such as endocrine therapy which often work just as well in improving survival and reducing distal metastasis and recurrence in appropriate patients. I think also as research goes on and time goes on, we're getting better and better ways of typing breast cancers, and it's already starting to appear that there are certain subtypes when assessed with DNA microarray that will respond perfectly well to surgery. So there's some subgroups where surgery is perfectly adequate treatment, but the others are going to require chemotherapy.